Well, good morning, everybody. Welcome back. It is our fourth event in the Patient Safety Summit and our final one, and super excited to have this one today. We had tons of posters that were submitted. The planning committee voted, and the top 3 posters are going to present for us today. So excited to hear about all their great work. But as I've said in the past sessions, please go to our webpage, and I will email you later today with that web page so that you can look at all the posters. That's where the evaluation will be. Everything you need to know will be there. So if we could go to the next slide, please. Everybody's pretty familiar with REMO at this point. Remember, you can go visit our sponsors before and after the event and visit them. We are having sponsor bingo, so we want to make sure that you are going into the room, click on the call to action button, which usually takes you to their web page, and then anybody who has been in all of the sponsor booths, at the end of today, we will do a drawing for Amazon gift cards. So please visit the sponsors. You can't now that we're live, but you can after the presentation is over. So we want to thank our sponsors. On the left side, when we're out of presentation mode, is going to be our platinum sponsors, and on the right side are our silver sponsors. Again, please go and visit them. So some of our platinum sponsors, and they're in alphabetical order, is JPS Health Network, Methodist Health System, and Texas Health Resources. We have a short video to show on all 3 of them, so we'll start that video in a second. Sorry, my name is Patty Taylor. I am the, sorry about that, guys, little technical issue. We'll get it figured out. Okay, thank you. And again, thank you to our platinum sponsors. We also had some silver sponsors. We had the American College of Healthcare Executives, the DFW Community Health Workers Association, the Texas Association of Healthcare Interpreters and Translators, and UTA Multi-Interprofessional Center for Health Informatics. So again, visit our sponsor booths and get in the prize drawing for the Amazon gift cards. So next, I'd like to thank the Patient Safety Summit Planning Committee. These people have worked very hard since January to put together this awesome session for you. So if you know them, reach out, say thank you. They did a lot of hard work. Yes, claps I see out there. That's wonderful. Without them, this wouldn't have taken place. So thank you to the committee. I talked about our posters being on our webpage. I will send you an email a little bit later with this link so that you can go to the webpage, look at all our posters, take the evaluation. Everything you need to know will be there. CEs are being offered if you attended the entire session. There's 7 for ANCC, 7 for CPHQ or CPPS, 6 for ASHRM. Unfortunately, today's session was not approved for ASHRM because we did not have the 30-day window to tell who the presenters were going to be since it was a contest. So sorry about that. But 7 self-reported CEs through ACHE. To claim your CEs, you have to complete 85% of the sessions, do the evaluation, which I actually decided to open it today. At the end of the day today, I am going to, in the chat, give you the link to the SurveyMonkey to take your evaluation. So when we're done, we keep the event open for 30 minutes. You can just click on that link and do your evaluation right away and have it all done and completed. Please give us 1 to 2 weeks after your evaluation is completed for us to email you your certificate. Again, all of the post-summit information is going to be on that webpage that I am going to email to you after the event. Everything you need to know, if you haven't gotten the gist of this, is on that webpage. We have found no conflict of interest with any of our speakers. So at this time, it is my pleasure to introduce our first poster winner for this presentation. They are from Baylor University Medical Center at Dallas. It is Bethany Ferguson and Courtney Brummett, and their poster was titled COVID Multimodal Communication Model. If you can come up on stage with me. Awesome, Bethany. Come here, Bethany.
Hello, everyone. My name is Bethany Ferguson. I'm a Director of Strategic Initiatives at Baylor Scott & White Health. And more importantly, joining me here today is Courtney Brummett. Courtney is the nurse manager of 12 Roberts, one of our 35-bed medicine and telemetry nursing units at Baylor University Medical Center, more recently denoted as a designated COVID unit. Today, we're going to be talking about communication through a multimodal model to support patient care in COVID. Similarly to Patty's disclaimer, no conflicts of interest. As far as the objectives of today, we want to share with you how leveraging technology can increase collaboration of the healthcare team, improve communication with the patient's family, and optimize patient satisfaction scores during a pandemic. We also have identified challenges and barriers in current practice related to innovation and virtual rounding. Additionally, we'll describe the roles and responsibilities in use of this tool and the implementation, and the focus required by multidisciplinary rounds using this tool. I'm not a clinician myself, so I'm about to turn it over to the expert here. I'm an industrial engineer by training. I've been with Baylor Scott & White for 13 years in a variety of process improvement roles and project management support roles. But I'm going to let Courtney give a little intro about her and then take it away.
Good morning, everyone. So I'm Courtney Brummett. I started my career here at Baylor in Dallas in 2014 as a graduate nurse. I was on a cardiothoracic surgical PCU. I was a very engaged bedside leader who took on roles of quality improvement, being a clinical preceptor, a relief charge nurse, and I found a love for leadership. So I pursued a career as a supervisor on my current unit, 12 Roberts, and then served as the interim manager and then the current manager, and I've been in that role for 2 years. I'm married and up to my husband, Darren, for 9 years and counting, and we have 2 boys, Titus and Eli. Next, I'm going to share a personal story from early in the pandemic that helped fuel and drive the beginning of our project. So there is something deeply devastating about the thought of someone dying alone. And there are international programs and initiatives built around the premise that no one should be by themselves at the end of their life. But what about during the height of a global pandemic with a disease that no one really knows enough about? We were seeing it in the news, we were trending the numbers related to mortality, and we were seeing hospital staff given trash bags instead of PPE, and there was a consistent feeling of panic and global fear. So how do you prioritize between exposure and presence when someone is taking their final but contagious last breath? This is a question that we asked ourselves really early on in the pandemic. And one of our first COVID positive admissions to our unit was from a nursing home. It was a female in her 90s with a new code status of a DNR A&D and had no family in state. And so pretty quickly after she arrived to the unit, we found she was imminent in the dying process. But my team was scared, and we were having discussions every hour regarding safety, clustering your care. I'm sure many of you experienced this as well. But at the same time, they had voiced some distress around the idea of her last moments being in isolation. And this was the first time we were experiencing family being separated from the bedside. And normally in this kind of situation, we would have had our chaplains be there for support, but they weren't going into the rooms either. And so we as a staff, including myself, signed up for rotation so we could be the family and the friends and the grandchildren, the neighbor, the prayer warriors, things that were normal before this moment. So we could give her dignity in her death and compassion and empathy for our presence at her bedside. But the question we were asking ourselves is what cost? At what cost would that be to be present in that patient's room? And so we had found a gap that would need to be filled. And the solution would need to provide a safe encounter for our clinicians to see and interact with their patients, and also meet the need to allow those within the patient's inner circle to be with them in their time of crisis. And so I'm excited to share how we accomplished this, and just so much more. So to give some background, the very first patient admitted to Baylor Dallas occurred in early February of 2020 into one of our ICUs. Our numbers continue to rise, and 8 Roberts, which is a pulmonary specialty medicine unit, transitioned to a full containment unit on March 14th. I had given myself a false sense of security, thinking that my highly coveted telebeds, we had no chance of caring for COVID, because heart failure and chest pain was still a priority. But less than 2 weeks later, on March 27th, 12 Roberts transitioned to be in a COVID unit. Our focus was to keep our team safe, to conserve PPE, restrict visitors as potential exposures, but also to provide the same exceptional care and patient experience encounters that we had been doing just the day before on March 26th. But keep in mind, everything felt like it was changing, and sometimes it felt it was every hour, every minute, and we had no virtual communication platform that operated at the level that we needed, and the fear across the healthcare field nationwide was palpable. So instead of just talking about our problems, we combined with our lean team and we wrote them all down. So here you're going to see our problem analysis tree. It's very busy, but we narrowed our focus to COVID's impact on our daily workflow and the quantitative data from our HCAPs. And we created this problem analysis tree that helps to really simplify what our next steps would be to facilitate our progress and create solutions. From the lack of technology to support the virtual rounds, to the challenges of social distancing, to the PPE shortages and training limitations on what staff could enter our patient rooms, it was becoming more and more evident that COVID's impact was ever growing and completely changing many aspects of our daily practice. Even transporting our patients from the ED to our unit had become complicated, the simplest of things. With our new understanding regarding the depth of our problem, our next steps forward were determined, and we focused our ideas to create some innovative resolutions. So step one, we needed to create the technology. So Bumsy and 12 Roberts responded and engaged a multidisciplinary team that had frontline staff, leaders, IT support, Microsoft Teams, product key stakeholders, as well as our medical providers. And we went forth to update an existing product to meet the needs of our current global pandemic. We shared inventive ideas and what we really wanted this product to achieve. It needed to fully support the clinical needs of our providers, nurses, and the ancillary team, but also provide the patients with a way to connect that was meaningful with their loved ones. It also needed to be secure, safe, and reliable. So instead of making just one thing, we ended up making 2 things. So BSW Round and BSW Meet are the 2 in-house Microsoft Teams applications that were improved based upon that feedback. Clinicians can access this through our Zebra phones or Rover devices. They can also do it on their personal phones or their desktop. From this app, we were also able to invite their guests and family to connect and visit virtually. BSW Meet is the app that's on the iPad or the patient consult device that remains in the patient room. So if you look over to the side of the screen, there's some images there. And my models in this picture are Mido. She's a nurse here in 12 Roberts. She's been at BUMC for 4 years, and she's the chair of my shared governance council. And then our patient there is Steve Tavenaugh. He's a nurse at BUMC, been here for around 4 years as well, and he's one of my clinical nurse supervisors. In that first image, Maya is hitting join on the iPad. And in the second image, she's using her Zebra phone from the hallway to round on the patient. And in the third image, that's what Steve will see in his room with our nurse, on the other end of the hallway. One of the most celebrated uses of our technology was helping to bring loved ones back to the bedside virtually. After the provider, the family give us their email address, the RN then can enter it securely on that app and through the DSW Run app on their phone. The email is then sent to the family member and it's immediate and it's through that invitation only. After they join, the nurse admits them from their phone and then they are able to visit and see the patient. It is private and secure and it's a wonderful way to kind of have that face-to-face connection that they're looking for. Here in my picture, you can see Dr. Hodges. He's one of our hospitalists. He's rounding again with our patient, Steve. And in that second image, his family has joined. It's not really his family. It's actually an 8 Roberts nurse. Her name is Emily Searle. She is actually one of the DFW Great 100 nurse recipients this year. And many providers were able to have goals of peer discussions or family conferences involving the patient through this platform. And like Dr. Hodges, they were able to conserve PPE and emphasize safety. One challenge that we had to overcome during the pandemic was rolling out a new thing like this was the education. And so the way that we helped this project overcome this barrier was leveraging technology to then teach our teams. We collaborated with our informatics nurses and our IT team to create video resources for both clinicians and then also our patients, as well as a how-to guide to troubleshoot the devices. We laminated these and connected them to the iPad stand so the resources were readily available to our frontline team members at the bedside and in the room. Because again, at this time, nurses were really the only ones going into those patient rooms. The team also provided links to SharePoint sites for those clinical-based resources. We put them all in one place. It included all the videos, tip sheets, and the FAQs to help guide our staff. And on 12 Roberts, we would play the videos at the nurses station throughout the day, so it was readily available kind of all the time to learn. So here you can see that when we launched the app in May of 2020, we had 605 connections or rounds. And when we peaked as a hospital for our COVID admissions, we also peaked in December with our connections with 25,948 connections that month across our system. Implementation of the devices into our rooms allowed for spread to our ancillary people like chaplain services, specialists, providers, PT/OT. In order to foster that education of them, our current end users, which were again the nurses and PCTs on the floor, trained those ancillary team members on how to use the devices, as well as the location of the resources on the SharePoint site. And here at Baylor, right, we believe in making healthcare better and fostering new ideas. And so some of the best innovations we found came from our nurses, as well as our other staff, just original uses for the technology. Here I have Ariane. She used the technology to virtually round one of her patients who kept taking off their oxygen. And so she used the app to gently remind the patient to put it back on all throughout the shift and keeping them safe. And then Shelby, one of our nurses, used the app on the Zebra phone to round on our high fall risk patient, not having to go in again and again and put on those PPE, but then still able to keep him safe from injury during her shift. The final aspect of our project, so we did a lot of stuff, but the final piece of it, with a goal again to create a pre-pandemic patient experience while still in the throes of COVID, was the creation of a COVID communication toolkit. So we worked with Alyssa, who is our patient experience director, and our lean team again, who are just so wonderful and fundamental in making great processes. They helped us to standardize how we would consistently update a patient's primary contact. Also document that update, provide scripting, make an updated admission letter, to ensure that our team felt kind of consistent and prepared for those conversations. We also wanted to normalize and re-implement some of the practices that we had stopped at the beginning of the pandemic, and this included a daily huddle with our MDR, or multidisciplinary team, to address length of stay and discharge needs. So the first thing of that kind of group is the update of the primary contact. And so on the left, you can see that the decision tree that we made was to help assist the team to first identify the primary contact, second, who would be responsible to then do the daily update, either if the patient, if they were able, or the clinical team member, and then lastly, to ensure the primary contact knew to spread that information to the rest of the family. This really helped to reduce calls to our team and ensure that our patient's family remained informed. But when calling the families, it became very evident that there was a lot of questions and concerns and anxiety around all of this because they weren't able to visit. So we recognized that challenge and took the feedback back to our staff and got the frequently asked questions from the family, and we created this template and scripting for them so they could ensure that they were telling them about our protocols, that they would feel safe or what they should share. And this was not really an exhaustive list, but it did give them a starting point and guidelines that ensured the message and updates was cohesive and consistent. And then a part of that toolkit, again, was that COVID admission letter. We really wanted to kind of update what their stay would look like. We wanted to give uniformity to that expectation. On our unit, and I'm sure like many of your units, we had lots of floating staff and agency. And so we wanted that message to be unified. This split through marketing. So I made the original one, and this is so much better and so prettier than what I had originally done. So marketing really made it better. And then we also have that translated into Spanish. On the top right, that's the guide that we used to standardize our process to implement MDRs again, which is our multiple disciplinary round. During the MDR, the must-haves were outlined when discussing the plan of care for our COVID patients, right? Because they were a little bit different as what their needs were. So we wanted to talk about discharge planning, tele needs, updating the family, and the isolation requirements or testing. And then the bottom area is with all things in healthcare, if you don't document it, it didn't happen. And so we applied the standard to that primary contact update as well. Epic had already had a great built-in location for us to do this conversation. We shared it as a tip sheet with our team and encouraged them to document between 10 a.m. and 8 p.m. And that information was included in that admission letter as well. So next, Bethany's going to share about our results and how this spread across our system.
Thanks, Courtney. And what I'll tell you is I don't take credit for any of this, but these results that you see here is what got me involved in the project. So this is a measure of patient satisfaction scores on the domain of communication with the nurses. The baseline here is from April of 2020, so really in the throes of the pandemic, sitting at 66 points here. The same time the year before was 13% higher than that. So we knew that the visitation policy, a lot of the unknowns and the fear around the pandemic in general but especially the limitations that we had with our nurses being able to communicate effectively with our patients in person was creating a negative impact on our patient satisfaction scores. We implemented this BSW Meet and BSW Round Teams application in May, and we saw an immediate improvement. We saw sustained that improvement for a little bit. And then as census got higher, as we had additional surges, as staffing became more challenging, we did see a decline. And throughout the summer and fall here, we did additional implementations and reviews, remediations to improve processes as it relates to the multidisciplinary rounding work, as it relates to discharge planning and education. And we've been able to recover from that little dip and maintain that progress all the way up till now. What we've seen is just a continued increased consistency in the use of the tool and in using the tool to apply to the specific needs of the patient. We also were able to involve at Baylor University Medical Center the Patient Family Advisory Council. That's a group of former patients and their family members who we bring initiatives to, and they review and provide feedback on things that we're doing in the hospital. They had a number of questions that we were able to help answer and help with that. Their feedback was a lot of what implemented different changes to scripting and different changes to education to make it more effective for our patients. I'm going to take most of the rest of the time here from our presentation. I want to share some other personal stories, but before I do that, what I'll tell you is that the personal stories that came out of 12 Roberts, then our system chief nursing officer saw the results on patient satisfaction, heard the results on personal stories, and said, we need this across our system immediately. So my role in this project was to spread it to the rest of Baylor Scott and White. You know, not a small feat, quite a number of hospitals across the state of Texas, all at different stages in their COVID census and in the urgency of need. So we lined up every single hospital, put them on a go live schedule, usually about a week apart, identified all the folks involved, and then started deploying everything that Courtney and her team had done all the hard work to prepare for us across the system. That deployment included providing background and education on the results of everything that had been experienced at BUMPSI, doing a lot of technical setup with our IS teams, and then providing testing demonstrations and training on real live scenarios of testing that device, similarly to how you saw the pictures of my, even for this presentation, demonstrating that for the pictures here. And then lastly, identifying adoption metrics to be able to monitor, is the technology being used? Is it providing the experience we expect? And we were really excited that as part of that initial pilot success and then subsequent deployment, this project won the 2021 Exemplary Business Unit Improvement Project for our Safety and Quality Summit Awards, excuse me, here at Baylor Scott & White, named after Bill Aston. So I want to, I think I have time. Well, how much time do we have, Patty?
You have about 1 to 2 minutes.
All right. So we might not have time for that. Some additional lessons learned. Throughout our journey, we've learned lessons that we have shared with each subsequent rollout. One of the big lessons we learned was around clinician-based education, making sure that we had that. And the second bullet here was probably the primary learning, earlier securement of devices. You've heard us talk a lot about devices, iPads and Zebra phones and things like that. We recognized early on that in order to maintain ownership of those iPads in the patient rooms, we would need a secure setup. So we were able to invest in what we call an IV pole for an iPad. So a stand on wheels that we can lock the iPad to, and they walked off significantly less often after that. Additionally, if we're going to have an iPad running a video conferencing call for the majority of the day, that drains the battery pretty significantly. So investing in charging cables that are long enough to keep that iPad plugged in consistently so that it can be used and is always ready when the clinicians need it. So that was a big learning from some of our earlier hospitals that our later implementations were able to implement early, and they saw greater success. We improved consistently, going back over to improve scripting, education, to educate patients and family members on the use of this tool, to reassure them of the security regarding privacy concerns and etiquette, and really great partnership between the nursing teams, the information services teams, the informatics teams, and everyone who had to come together to make this a successful implementation and a successful deployment. Some key things about lessons learned going forward. We're now looking at this not only as a technology during this COVID pandemic, when we've got the visitor restrictions and the PPE requirements, but we're looking at it as a continual tool in hospice care, as you heard about Courtney's story. We're looking at it as a continual tool potentially for remote specialist consults. How do we continue to enable face-to-face communication with the patient and whatever resource that they need at that time in their care? This is a platform that can enable us to do that at greater efficiency for the healthcare system and a lot more effectiveness for the patient to have that interaction. We're committed to finding innovative ways to continue to improve and expand this technology, and we're excited about making healthcare better in this way. And that's the end.
Thank you.
Thank you both. You're getting lots of claps in the chat. Great presentation. There are a few comments I just have to read. So it's excellent work and very proud of the team. You all made a huge difference in the lives of patients and the gift of connection for our patients and families at the highest time of their anxiety. Wonderful work. We did have, which you answered, somebody said post-COVID, what are you going to do? And you talked about that, so wonderful. We did have one other question on, did you ever run into a family member not having a device to be able to communicate with the patient, and what did you do?
Yes. So they needed, in order to use the DSW Round and DSW Meet app, they needed to have an email. And so there was a couple of people that did not have that. Then we kind of went to some of the more rudimentary things where if the patient had a cell phone, we would help them set up to do like their own FaceTime or something. In worst case situations, nurses would volunteer to do that. But we really, in order for that to be secure, we really kind of deviated to this app as our primary focus. But we did have some of those situations, and we actually helped some people create emails so they could have that as far as, having that service orientation. But there was very few instances where we weren't successful in making that, and people were really excited to do that with their patients or with their family members that had COVID on our team. And it was a great product, like you said, to create that connection in the height of anxiety in the middle of the pandemic.
Awesome. And again, more comments coming in about awesome work. Congratulations. It was and how quickly you did it too. That says a whole lot. And as you said, Bethany, Baylor Scott & White has a few hospitals that you had to implement. So great job. Thank you both very much. I will now introduce our next speaker. So our second poster presentation is from Children's Health, Diana Montoya and Jennifer Brown, on improving pediatric healthcare workers' personal safety through the implementation of a behavioral rapid response team. So if Diana and Jennifer can join me on stage. Here's Diana. And there's Jennifer. I'll turn it over to you guys.
Thank you, Patty. That intro title is a mouthful, isn't it? I didn't realize it until I heard somebody else say it. I was like, wow, that's a really long title. So before we get started, I do want to kind of give a little bit of background about Diana and myself. I'm Jen Brown. I am one of the team leads for clinical education. I cover psychiatry and behavioral health. I've been at Children's for a little over 21 years. Diana Montoya, my peer, is also a team lead clinical educator, and she covers both the neurosciences unit as well as the CRT PCT group. So a lot of her folks have a lot of vested interest in the outcomes related to this particular poster. So let's go ahead and get started. Oops. Before we actually change slides, I do want everybody just to take a moment and look at that picture for a second, because these are the people and the disciplines that we are going to be talking about today. And as you can see, it's a group, and we will get a little bit more into that, but I just want to kind of take a moment to call attention to the people who really helped get this team up and going. So let's talk for a second about some objectives today. I do want to let you know, Diana and I have no disclosures either regarding the content related here, although I will say this is something that Diana and I both have been very passionate about for a long time. And so we do have a long-term vested interest in how this played out and how it continues to be refined today to produce the kind of outcomes that it is producing. So our objectives here, we're hopefully going to show you how looking at the data really drove the implementation of this program. We're going to talk about the content delivery systems and methods that we utilized for the Bert team itself. As educators, Diana and I, that's our area of specialty, to ensure that content is delivered in a very meaningful, productive way to help people feel confident in their roles. And then that third one is to identify the impact of the response team in relation to the effects of personal safety. So kind of keep that part in mind as we look at data and outcomes. So before we get started, kind of go back one slide, Diana, because I don't want to kind of give it away. I do want to talk a little bit about the background. Having been at Children's for a very long time, the concept and discussion of behavior response teams has come around more than once, more like several times in my tenure here. And as groups of us met, we always discussed things like current training, looked at outcomes related to both patient safety, where these events occurred, and we also looked at benchmarking and found that as an organization, we created initial and ongoing annual training related to de-escalation, physical interventions for more than just the team. Like, as long as I've been at Children's, this has been a house-wide expectation. And so over the years, when we talked about these teams, we really felt like, you know, as a overarching theme, staff were getting what they needed to help prevent and reduce risks. And the outcomes and data kind of followed that for a time. Additionally, in looking at like lit searches, those people who responded to emergent events were security. And rightly so, I think everybody here, you know, in your organizations, if you work in a healthcare system, those are the very people who end up responding. So we felt like we were on track. This was, you know, prior to 2018. So in 2018, I got another call and it was like, hey, we're going to talk about this behavior response team. And I remember kind of going, oh, are we going to just talk about this again? Or, you know, like, what are we going to do different? But this time it felt different from the start. We had different stakeholders. It was more robust. And the talks were around new data, making sure that we had what we need. So what exactly did the data tell us? So that's a little bit of background. Now we're going to look at the data. So as you can see, we kind of divided it twofold. We looked at national data. We did searches just like we had done in years prior. We looked at evidence-based practice. More and more hospitals and healthcare systems were utilizing a formalized behavioral intervention team or response. And so the other thing is, from a national perspective, workplace violence was on the rise, evidence-based practice, peer-reviewed articles were out there about it, and those things were being felt within our organization. And so I think those things really help solidify, okay, we need to look at this again. And so the group of us looked at children's specific data. And because security were primarily the responders of these types of events, that was one of the main focal points. And we divided it up based in two parts: the uncooperative patient, so that was patient specific, and then quote unquote disturbances, which could include visitors and family members. So as you can see, you know, if you blow it up over time, those numbers had grown, right? And we know that all things are most likely underreported. And so in looking at this data, it was like, okay, wow, we are trending upwardly. We also looked at injuries, locations of events again, and we looked at our de-escalation training, the numbers of people that were coming through, how that was being handled. Content was always being updated in that, but we were really starting to hear and see it wasn't necessarily enough. And so before we actually started the program, Diana and I created a pre-survey that we sent out to bedside staff, and we asked questions related to their perceived feeling of safety related to how confident they felt intervening or caring for a deregulated patient or in an escalated circumstance. And as you can see from our data here, 72% of those staff members responded either neutrally or disagreed. And for us, that was concerning, because the other thing I didn't say, Diane and I both are instructors for that annual de-escalation training. And so for us, we feel like we're teaching these things, but that's not what the numbers indicated. And so again, for us, it was like, okay, we've got to do something. What does that look like? And so these data points really helped solidify there needed to be improvement, both for our patients and the outcomes, but for the staff members, right? And for our organization, one of our key priorities is the people, our staff. And so we always want to make sure that we are reinforcing at the staff level that the organization recognizes not only the work they do, but that their safety is important as well as the patients. And so we do feel like confidence impacts the way they provide care. So creating the system inadvertently helps create better outcomes for both patients and our staff. So we moved forward with creating some solutions. Next slide, please. So what were those solutions? We went back, looked at our peer children's organizations, other healthcare systems, looked at who made up those teams. Again, it was primarily security. If they had psychiatric specialties in organizations, those folks were a part of teams, sometimes social work. And at Children's, one of the things I love about our organization, right, it's not only what's going on out there, but how can we take it a step further? And so what we did is really look at incorporating a true holistic, multidisciplinary response team. And so, thinking back, and Dinah, you don't have to flip back, but thinking back at that very first picture on our slide, the team members that respond to the Berts consist of the patient's bedside nurse, their charge, the patient's primary provider. They are 100% engaged and continually responsible. The response team is not a takeover team, but a support team, because we aren't talking about the need to come in and take over in an aspect that bedside staff can't do, because they still get the annual training, which communication and de-escalation is a key factor. So those who respond in person are administrative supervisors who help not only ensure that all team members are there, but they look at continued staffing needs for these patients who are needing the extra support of response teams. Psychiatry consult providers who help with assistance related to if there are any behavioral or mental health diagnoses. They help the primary physician with behavioral medication interventions. Pharmacy in conjunction responds with what we call a Bert bag. That bag has those medications, because one of the things that we knew in our data was in a de-escalated situation, if medication was recommended, that medication that might be appropriate to help with those interventions aren't readily available in the Omnicell of those areas like the ED or the med floors. So having that pharmacist respond helped decrease that time to medication, decrease tremendously. Social work is involved. They help with that holistic family systems perspective, on top of the fact that they assist in debriefing with the Bert team after, in case there are any kind of moral residue or issues within the Bert team themselves to identify areas of improvement. Psychiatry, the nurses respond. They can assist with the de-escalation, behavior modification, environmental modification. They can help the bedside nurse do med education, that kind of thing, with both patient and staff, because they may not have that knowledge or expertise. And then if a situation did get physical to the point of restraint, those psych nurses are very well versed in regulatory standards related to documentation and can help the bedside nurse with that. And then security. And we all know security is phenomenal. They can help in de-escalation. But for us, one of the primary objectives for security was to help promote a system of support. They can help de-escalate. They can help with crowd control. We all know as things tend to get chaotic, the more people tend to kind of come along and rubberneck, if you will. So they do help with diverting people and those kinds of things to reduce stimulation. So those are the Bert team members. Again, very robust, lots of expertise. So with this solution, we additionally created another pathway. So our solution was a 2-path approach, but the poster today just focuses on the Bert. The other approach is a proactive, what we call a collaborative approach to preventing escalation. It's just a formal phone call communication to help problem solve when things are not escalated. So just like a preparation, let's brainstorm some ideas kind of approach. But our poster today focuses on that in-person response because it directly impacted staff's feelings of safety as well as those outcomes. So as I turn it over to Diana, who's going to actually talk about the training path, I do just want to kind of keep in mind that from a systems perspective, this response team only responds to our inpatient areas, and our, what we call our Bright building, was just one ancillary building connected to the main hospital, not the outpatient service areas. So Diana, do you want to take it over and talk about our training plan?
I'd love to. Thank you. So we have this great program, and we can't take all the credit for that. We have a great program project group that helped us through it and really wrote the policies. And so Jennifer and I were, okay, this is great. How are we going to educate our staff members to follow through and actually know what they're supposed to be doing? So if you want to get out your phone, you can go ahead and scan this QR code. So it's just a visual breakdown of the training plan that we developed. So we knew that we had a couple different barriers that we had to overcome, one being large numbers of people that need to be trained in this in a very short turnaround time. So to overcome these things, we really did a kind of a 2-tier approach and used multimodal delivery methods. So if you look at this 1-page document here, again with the QR code, you can see the top part was really meeting the learning needs of our clinical staff members that would actually call on the Bert. And then that bottom is where we spent the majority of the time, where we were developing specialized education for our Bert members. So I'm going to focus mainly on the Bert staff training plan. Again, at the bottom, this consisted of CBTs, multiple computer-based trainings, a 3-part simulation, really getting into that application of what they learned in those CBTs, and then a 6-month follow-up instructor-led training after the Bert went live. This was really important because the Bert team members came and they socially learned through each other by discussing, hey, I responded last week and this is what happened. This is what went well. These are my struggles right now as a response team. Are you guys feeling the same way? So really driving on empathy and social learning. Also included in the Bert response is debriefing. So essentially we had this with our Bert team members, but debriefing is a key element to the response team to identify successes that were within that time frame, and also opportunities. Where can we grow? We always want to see that. So this class allowed for the Bert team to really get together, bring their past experiences, and socially learn from their peers. Also included in this was one more follow-up simulation to really get hands-on, dive in, let's practice one more time. Going into our results, so you can see we trained a lot of people within 3 months. So over 2,000 multidisciplinary staff viewed this introductory video. This was really important because it was flexible, it was on demand, they could actually do it on their phone if they wanted to, and we tracked that through our platform, which was Cornerstone. So that really allowed for us to train a large audience in a short time frame. And then you can see over 1,000 nurses completed that computer-based training. Again, they needed a little bit more specific knowledge for their role. And then 74 Bert team members were trained in a matter of 3 weeks so that we could get them up and running and responding. They had to get trained before they could respond to any patient responses. And then also we curated the content for quick reference guides within our intranet. So this was super important because, you know, outside of the Bert members, there are some staff members that don't routinely live and breathe this workflow. So it was really a way that 6 months from then, when they needed it, the information was all there. It was curated for them right at their fingertips. And then you all want to know about this. So what was our impact in safety? So as Jen referred to in the past, we did a pre-survey and then we did a post-survey 1 year after implementing the Bert. So if you can see on this graph, the pre-survey is in the light blue and the post-survey, again, 1 year after implementation, is in the purple. So really focusing on that shift from that disagree and strongly disagree in the light blue, it shifted over in the purple to be either in that neutral, agree, and strongly disagree. We found a lot of growth in that agree area. So it went from 16% to 40% after implementation. And again, just to refer you back to what this question was saying, it said, I feel personal safety when caring for a patient with aggressive behaviors. So that was a huge win for me and Jen, feeling that 40% felt personal safety agrees, 10% strongly agree, and really shifting those strongly disagree and disagree into those positive. Oops. Okay. And then this was just a personal impact statement from one of our nurses down in, we have acute care services, so our inpatients. So she said, the timely response of the Bert team helped keep my patient from getting off the unit. The entire Bert team went above and beyond to keep the patient and staff safe. Then you can also see this is from a nurse who was down in the emergency room, which we know they're boarded down there a lot of times. So the Bert team is a much needed resource. The team kept everyone calm and confident when we had 2 events at the same time. Janelle was awesome with ensuring everyone's documentation was complete and accurate. And Janelle is one of our inpatient psychiatric nurses who is phenomenal. So she was part of that Bert response and was called out for her help with being there and helping with documentation, which is sometimes cumbersome. So again, both of us, Jennifer Brown and myself, we are a part of this project team, which was a finite project, but it continues to evolve. And we are currently working on 2 other projects right now related to patient safety and staff safety with aggressive patients. And then we also implemented the Bert on our 2 satellite campuses within the past 2 years. We would love for you to reach out to us. Our emails are listed there. We always love collaboration and partnership within organizations outside. Don't think you have to be a pediatric organization to reach out to us because, again, there are things to learn from each other. So please feel free to reach out to us. And then we also have our references here.
Thank you, Jen and Diana. Great presentation, great work that you did, getting lots of claps in the chat, lots of comments. There was one comment that I would like to address, if you don't mind. It just said, I don't know if the workplace violence has increased or reporting has increased over the 20 years I've been in the healthcare field. We just dealt with it. We didn't report it unless someone hit or bit us. And I've been in for 35 years, and that is the way it was. But the whole mindset is to change that now. We did start a workplace violence committee at the Dallas-Fort Worth Hospital Council back in June. A hospital reached out and said, you know, with COVID, it kind of calmed down because there weren't very many visitors there. But then after we opened up our visitation policy, he even stated that the severity of the injuries has really increased. So we will be highlighting workplace violence on our KRLD radio show in October. And we're going to have 2 guest speakers. This is on, it's called The Human Side of Healthcare. It's on Sundays, and it's also broadcast in Spanish because we want the community to know this is unacceptable. I don't think they realize they're stepping over a bound. So we're going to do that radio show and hopefully get more awareness on this. So great work, guys. Good job. Yep. Thanks out there. All right. So our next one up, last but not least, is from Baylor University Medical Center, Dallas, Cindy Cassidy and Chick Deegan, Joy in Work. And boy, do we all need some joy in work. We thought this would be a great way to end our event. We did a lot on mental health, and this is going to be a great presentation. So if Cindy and Chick can join me on stage. Hi, Cindy. Great, and there's Chick.
All right, good morning, everybody. No pressure there. We've got to make sure we end up with some positive joy. I am Cindy Cassidy. I'm the Director of Quality and Patient Safety at Baylor University Medical Center at Dallas. And I have the privilege of presenting Joy in Work with the great Chick Deegan. She has recently retired, but she's still an acting volunteer, and she provides continuing staff spiritual support. So I'm going to be presenting the project to you, and she will be available for questions with myself afterwards. All right, so we're going to cover 3 objectives in our time together. For some of you, you may not have even read about the IHI Joy in Work framework, and so I'm going to introduce that to you, or maybe reintroduce it to some of you. We're going to talk a little bit about core principles, core practices, and processes for developing what Chick and I call the inside-out transformational leadership. We're also going to talk about measurement. How do we even measure joy in work? So we're going to talk about one example of that. And here's the problem we're trying to solve, and maybe some of you can identify with some of the things we're going to talk about. So there are limited efforts to enhance joy, resilience, and self-care for department managers. There's lots of literature that talks about joy and resilience, especially related to COVID with nursing and maybe some other clinical practices, but I didn't find a whole lot of literature about department managers. So why department managers? And I would also say that IHI framework can be applied to anybody, but this is just who we chose at BUMC. And this is why. These are actual statements from our BUMC department managers where they say, I feel like there's never a start or a stop in my job. Or one explains, I feel like there's a ladder that goes up in the air is thinner, the ladder just keeps going higher and higher. Another one, and this actually is something we continue to discuss, they feel like they're not enough. They feel like they're a fake, a fraud, even use the word imposter syndrome. Why did they even hire me? I can't do this job. They also say that it's a mental battle to start working so that they can provide self-care. And then last but not least, they feel like they're 100% responsible for everything that happens in their department, but there's things they cannot control. But the bottom line is they continue to ask themselves, where's the grace for us? And am I enough? Here's what IHI printed in the 2017 white paper on joy in work. Here's the background. So they say that joy is much more than the absence of burnout. Joy is one of healthcare's greatest assets. It should be naturally joyful to care for our patients. Healing should be naturally joyful. Joy is about connections. It's connections to our purpose and our meaning, why we come to work every day. I also believe it's the fundamental right to everyone. And then for the safety people in the team, like myself, you cannot make improvement efforts, you can't make changes without joy. It's the crucial component of the psychology of change. If that's not enough, here's a few stats for you, and these are probably worse off post-COVID or in COVID. Half of our physicians report burnout, a third of new nurses seek jobs within the first year of employment. Joy in work impacts much more than just burnout. Lots of other metrics, as you can see there. And if we do a good job with all those metrics, then we're going to substantially lower organizational costs. The triple aim of healthcare, it can't be achieved without the quadruple aim that IHI has dedicated to workforce safety, workforce security. And then for the nurses in the room, it clearly aligns with our magnet mission for a healthy workplace environment. And so here's another motivating factor. If that's not enough, introduce COVID. This is actual numbers from BUMC from July to December, inpatient COVID patients. And this is 1 week at a glance. And you can see our highest week back in December was 948 patients. That was about 180 patients a day that our staff was seeing, that our department managers were trying to go through. And then here's the stressors. Maybe you've experienced one, if not more of these stressors. I know I have. I remember when they told me that I was going to homeschool my child, and I just had no idea how I would do that with working as well. But I think we can all say that it just produced general fear and anxiety and a loss of freedom and a way of life as we know it. Here's the BUMC background. This is what our cohort is all about. We basically examined department managers and the effect of a 32-week, 16-session cohort using the IHI framework. And so the cohort included 8 volunteer, 8 nurse managers, and 1 physical medicine manager. We just asked for volunteers. Within 24 hours, we got these 9. So 32-week equips these managers with just core principles and practices to how to respond to the difficult moments in their lives with self-kindness, self-care, self-understanding, as well as taking care of each other. And then here's the measurement. This is ProQual. Many of you may not be familiar with it. I know I wasn't. I'm still learning about it. But it's a very reputable evidence-based scale, and it measures 3 things. It measures compassion satisfaction, where higher is favorable, but it also measures burnout and secondary traumatic stress, where lower is favorable. And you can see the baseline. That's 9 of their department managers, where they fell. This will make a lot more sense when we look at the post data. But also take note that there's different levels within each subcomponent, because we want to make sure if we didn't make our goal, that at least they move to a more favorable level within the subcomponents of ProQual. And this is our aim statement. This is a cultural improvement effort. So Chick and I were just happy to have at least 5% improvement, because we had about 6 or 7 months to get this done. But again, 5% improvement of using the ProQual scale with BUMC department managers by July using the IHI framework. And then you can see the baseline and then what 5% would look like. So let me introduce you to the IHI framework. There's really 2 pieces to it. And IHI continues to teach us that there's 9 critical components for ensuring healthy, happy, productive people, or joyful and engaged workforce. And so when you look at the wheel here, maybe one thing is more applicable to you, or maybe it matters more to you than maybe it does to me. And that's kind of the simplicity of the steps that I'm about to introduce. But all of these are equally weighted, equally important, it's about what matters to each person. And so the steps to the joy in work, as IHI introduces in the framework, is you just open dialogue, ask your staff. And so for here, for our cohort, for our department managers, we ask them, what matters to you? And we did this not just once, but on a continuing basis. And you have to do it in a safe, psychological safe manner, just to kind of keep it free and making sure that there's trust there, because that's really hard not to jump in and fix things. So about what matters to you, what are the pebbles that get in the way? What are the unique impediments to what matters to them? And then making sure that as an organization that we're sharing this responsibility of joy. We're responsible for everybody, managers, leaders, as well as executive leaders. And then last but not least, the last step is science and validated approaches to improving joy, process improvement, once you are able to identify the unique impediments. And what IHI says is if you do these 4 steps and you do these on a regular basis, then you're going to get the outcomes. And so when we asked our department managers the what matters questions time and time again, there was a common denominator. And I would say it really fell in these 3 boxes. It fell into the box of wellness and resilience, camaraderie and teamwork, and meaning and purpose. And so what that did for Chick and I is that's how we kind of created the agendas with each session. These are the root causes. This is what we focused on to figure out what we were going to do to intervene. What are the department managers at risk for? So number 1, there wasn't any measurement. We didn't know how we were going to see if anything that we did really mattered or made any improvement. So we needed to find some way to measure, and that again is ProQual. But also, even in a place our size, in a huge system like Baylor Scott and White, there's limited efforts, or sometimes no efforts, to bolster department manager wellness, resilience, meaning and purpose, camaraderie, in a way that matters to each person. No boundaries between personal and work, lots of fear, anxiety, vulnerabilities, again, imposter syndrome, we talked a lot about that. But also, unless there's a problem, even with these 9 department managers, they rarely found community amongst themselves, even some of them that worked alongside in the same service line. Only time they ever reached out to each other was when there was a problem. And if you've ever been a department manager, I know I have for many, many years, the day-to-day workload is absolutely overwhelming. I think department manager is probably the hardest job in the hospital because you're accountable for everything that happens on your floor. You're accountable for action plans, hiring, firing, behavior, physician behavior, adverse events. It's just completely and totally overwhelming. And then we don't practice self-care consistently. I know at the very beginning, asking the department managers, hey, raise your hand and tell me if you've ever done journaling or meditation or yoga. And maybe 1 or 2 hands went up, but they did not practice it consistently and definitely didn't practice any kind of mindfulness. This is a busy slide, and so I'm just going to really highlight, but these are the multiple interventions and actions that we did from December to July. The list is getting longer and longer, and just take note that we introduced a lot of things like journaling and reflective practices. Brene Brown came into a lot of our discussions, but we reintroduced them and stacked them almost. It's not like we just did it once and it was, check the box and move on. It made a huge impact. It was really building on that knowledge, and it's all about what really mattered to the group. They drove the agenda. Here's a few examples. This is actually a picture of some of our department managers in our cohort. And we did an arts and crafts exercise, and we talked about what people see us on the outside of the mask, and mostly you can see rainbows and butterflies, right? Everything's just fine, a-okay, I can handle it, but on the inside of the mask is what really their vulnerabilities were, what they're feeling, what they're going through in their personal life. And it really helped us kind of dive into deep discussion. And it connected us because we had a lot of things in common. But this was done not just through arts and crafts, but again, some more things that we do on a continuing basis is journaling, meditation. The fellowship and group share, I would say, is the number 1 thing that they love. Sharing a meal together, a totem activity, music, problem solving. But the last thing we did, I think it was 2 weeks ago, is we introduced yoga. Only 1 person has ever done yoga before, and it was such a great thing. We're going to make sure she comes back. And here, besides the ProQual, these are other things we want to evaluate to measure our success. Qualitative statements, I think, are the most powerful. Are we doing what we said we were going to do? Is this making a difference with the cohort? We surveyed them 2 or 3 times just to see if we were actually on the mark. Share with that in a second. The leader attendance, we want to make sure that we have at least 75% attendance, and every other week we meet for an hour and a half since December, not missing 1 session, and we've had over 75% attendance. An interest in keeping the original cohort. We asked them, hey, do y'all want to stop meeting? Do you want to pause? And they said, no, we want to meet forever. So even today, we continue to meet. And then there's a great interest in a second cohort. Could be department managers, could be supervisors. There's just so many needs. So it really just depends, that we are going to have a second cohort for sure. But here's the outcomes. Again, it's kind of busy, so let me just kind of highlight. On the left of your screen, you can see the top 6 interventions, the what matters to them. And then you can see the ProQual results. Remember, the top blue line is what we want. Higher is favorable. That's our compassion satisfaction. The bottom two is burnout and secondary traumatic stress. We want lower. And you can see where we started in December and where we ended in June. But this slide probably will highlight more. Not only did we meet our goal of 5% improvement, we did way better than that. So for compassion satisfaction, we were almost 7% more favorable. For burnout, almost 18% more favorable, and for secondary traumatic stress, 21% favorable. This completely surprised me, but I was pleasantly surprised. The other thing you should note is looking at the p-value column, the bolded numbers show that this was statistically significant. And then also take note that we moved people in more favorable levels. So not only did we meet our 5% improvement, but we moved them in favorable levels within each component. So for example, if you look in the improvement column for compassion, it shows 1 or 11%. One person moved in a more favorable level. For burnout, 4 moved in a more favorable level. And for secondary traumatic stress, 3 did. So it was a great call out when we were looking at it. But here's really what matters to me and what keeps me going with this cohort. When we ask them, hey, what's the value of work when we are looking at our post-cohort results, they tell us time and time again that it's really all about networking with other people that have similar roles and responsibilities and hear how they handle situations as well as self-care. They love the fellowship. They feel like it's truly being in it together. They say they find joy in the class and they gain a ton of knowledge and coping skills. They feel like that because they can take care of themselves, they can take care of other people. And although uncomfortable, because there's still several that are very uncomfortable sharing, they really do realize that the self-reflection and the growth coming from being uncomfortable is good. They love being away from the grind. We meet face-to-face, socially distanced, in a nice, pretty room. In the cancer center, and it just gives them time to get away from the alarms and the alerts and all the noise. And then last but not least, one said, I signed up to be a part of this group, but I had no idea how much I would truly end up needing it. As business stewards, we have to talk about the financial analysis, and I'm just going to highlight this. Basically, we were able to show the business case for our BUMC executive team. And so with a small cost of attending the IHI Join Work virtual course and time away to do the course as well as the sessions, we could easily say that it substantially lowers organizational costs. This is all from the white paper. I mean, lost revenue for replacing one nurse manager is about $70,000, let's just say. So total cost savings is definitely over $60,000 plus. How are we going to sustain ourselves and how are we going to go to a second cohort? Well, there's a few examples written here. It can't be a top-down approach. This is not a mandated initiative or project. This has to be driven by those who want to sign up for it. So in this case, it has to be driven by department managers. You need to have dedicated resource to lead the cohort, and we're very blessed to have all these resources you see on the screen, but maybe now we can do a volunteer from an original cohort, and you really do need an executive sponsor. We have our Chief Nursing Officer, Carla, who's amazing. But if we're going to talk about sustainment of our cohort of the department managers, I would say, and maybe you can identify with this, these are the 3 things that are going to continue to drive outcomes for them. Talking about work inefficiency, balance of work life, and then last but not least, what can they control? All the things that we get from our organization that they feel may diminish meaning and commitment, what things can we control within that window? This idea is very spreadable. Some of the elements that they have learned, they have taken back to their department, although I make them promise that this is not about you and or not about the staff. This is about you, the person, taking self-care. But we've also shared this with many other people throughout Baylor Scott & White and outside of Baylor Scott & White as we're doing here. And here's our main lessons learned. Engagement of department managers is critical. If you're going to have this kind of group, keep that discussion organic, let it flow freely. Don't have these rigid agendas. Try not to overcorrect and give it time. Keep that number small. Under 10 is really ideal. A dedicated leader equipped in facilitating difficult discussion is important. We're really blessed to have Chick along for that. And then the use of poetry, journaling, music, art, all those things enhance reflective experiences. Don't be afraid to use those things. But if you don't hear anything else, from what I just mentioned, these are the three things I really want you to focus on. First of all, there's evidence. Joy in work yields purpose, connection, organizational impact, and it builds resilience. There's science behind this. IHI is one way to achieve sustainable resilience in a way that matters to each of us. That's what makes it unique, the framework. But last but not least, we have to figure out a way to integrate what matters, what really gives us joy, into our daily workflow, into our daily schedule. We're not going to sign up for a class. We're not going to do something after hours, even during our busy 12-hour shifts, 8-hour shifts. We need to figure out a way to opt out versus having them opt in. And so how can we integrate all these things about what matters into our daily work life? A special thank you to my executive sponsor, Carla, as well as the team here, which is our cohort team. And then again, a very special thank you to Chick. And that is all we have. Open for questions.
Cindy, if I could, before the questions, I think we've really touched on something that's important to a lot of the people that are on this call for their own needs, as well as for the people they work with. And just a couple things. Someone asked about totems, and the explanation of totems is in the slides. But I would say that what we did was we created safe spaces where they can tell their stories, where they feel heard, and where they can rejoin soul and role, where they can break down some of those barriers. We have some Brene Brown fans, and hard not to be, but one of the quotes that we've used with the group is, vulnerability is the core of shame and fear and our struggle for worthiness, but it appears that it's also the birthplace of joy, creativity, of belonging and love. And that's so true. And what we know is that caring and healing brings those of us in healthcare joy. And part of what we've helped people to learn is it's okay to take care of yourself in doing that. So I will stop there, and we're open for questions.
Thank you both very much. Great work. There are no questions, just lots of praise in the comments for you both. I think this was very inspirational, and to continue forward with other groups of people is amazing. Very good. For the audience, you can see now why the planning committee picked these three posters. I mean, we had some great posters, that's for sure, but these three really stood out. Everybody who spoke today, we really appreciate you giving your time, sharing your knowledge with us. It was absolutely wonderful. So thank you, everybody. So I did put in the comments the link to the evaluation. You may have to scroll up because we're getting a lot of really positive comments in the chat. We're going to keep the space open for about another 10 or 15 minutes, so you can go to the chat and hit that evaluation link, or our webpage where the evaluation link is also. Please remember to do your evaluations by the 15th of October and give us 1 to 2 weeks to email you your certificate. So again, thank you very much. In the evaluation, there are comments about this platform. This is the first time we've used Remo. We'd really like your feedback. Is it worth us using it again for future events? So any feedback that you can give, we sure would appreciate it. And again, thank you to all of our speakers. We really appreciate you. We'll leave the site open for a little bit, and the speakers are going to be at table 15 with us if you want to come and say hi.